Okay, so I think we will go on to the next session when Dr. Muchu comes back, then she can inform Lina or Wei. So the next session, the first speaker, we do not really need to introduce him. Is our very popular, very experienced Dr. Zhang Wei. His topic is cervical Ube technique. Welcome.
Can you see my screen?
Yes, we can.
Yeah. Thank you for the introduction of Upang Huang. I'm Dr. Zhang Wei from China. Today's topic is the UB clinical applications in cervical case. Include the indication, basic anatomy tools, and the CCA position, the location of the portals, surgical steps, and other technique. The indication in my center include the keyhole for the discectomy and decompression of the nerve canal, and URBD, and the single open door, and the spare tip technique for the CSM. The basic anatomy is similar to the lumbar procedure. The workspace is surrounded by the rotator muscle, and we retract the endoscopy. We can see the muscle, and so I think the anesthesia is very important. We can see the today's surgical demonstration. We need the excellent the muscle relax. Then we can have the enough the workspace. You can see the rotator, the muscle. Rotator muscle is very important. It can show you the right orientation. And there is an anatomy trip. It is located in the interspinal process. Sometimes there is no any tissue. There is a gap between the interspinal process, so it's very dangerous. If you insert the first root to build the portal, you'd better to check the CT or MR. Is there a flav ligament between the interspinal process? So for this case, you can see there is no anything, only the spinal cord. So it's very dangerous for the beginner to do the cervical UBE procedure. So we build the work portal. We insert the first root to the midline. If we insert the root too deep, sometimes we will damage the spinal cord for the anatomy trip. The cervical UB equipments is very simple, relatively small, and endoscopy, radiofrequency, special tools, small size kerosene punch, and high-speed drill. I often choose the 30-degree endoscopy, but I think the zero maybe is the first choice because it is similar to the open procedure. And why we choose the 30-degree? Because we often do the contralateral decompression. So the 30-degree endoscopy can supply the more big surgical field for the contralateral side. And radio frequency is produced by the bounce company. We call the small one is a nerve friend. I often use this small size radio frequency when I performed the thoracic or cervical case. It's very good. And the small size detector and the UBE retractor and the UBE semi-tuber to keep the outflow fluidly. And the high-speed drill, the protective sheath for removing the osteophyte. And for this case, I insert the protective sheath on the surface of the osteophyte in the axillary area of the nerve root. and to protect the spinal cord and the nerve root. Then I insert the high-speed drill along the tube to remove the osteophyte. How to choose the Carrington punch? I think 1 millimeter, 2 millimeter is good. About 130 degree is good because we need the dural no touch technique. If you choose the 90 degree Carrington punch, sometimes when we do the cervical canal decompression, it can touch the nerve structure. This is the high-speed drill I often used. It produced by the Chinese company. It is very short, about 7 to 10 centimeter, and nearly no exposed drill root. You can see the tip, no the high speed, there's no root, and I often choose the 2 millimeter or 3 millimeter diamond ball. General anesthesia, we can control the low blood pressure, and the deep anesthesia, the good mouth relax, and the jet plane position to keep the cervical is in the level, and the location of the two portals. The blue line, the yellow line is described by Dawson, is located in the medial margin of the pedicle, but I think it's more medial. So I choose the midline of the lateral mass for the blue line, and the disc space is the yellow line, and above 1 centimeter is endoscopy portal, and below 1 centimeter is a work portal. And this is the location of the two portals in the lateral X-ray, and it is located in the facet joint. And this is a picture of the patient. I often to build the work portal, I insert the first root to the junction of the spinal process and the laminar. The same method I build the endoscopy portal. I think the junction of the spinal process and the laminar is very safe. Then the endoscopy and the instruments meet with each other in the disc level. The viewpoint is very important, and we start do the bone work from the viewpoint, and we use the size of the diamond to measure the decompression area. And we often to do the fixation, especially the lateral mass screw. I often expose the lateral mass joint under the endoscopy. The start point is the viewpoint. We do the bone work from this area. The anatomy of flavic ligament is very important for the decompression. You can see the lateral margin of the flavic ligament, and there is a membrane. I think if you want to get a good result, you must remove this membrane. This is not the dura, but it is covered the nerve root. So if you want to get the enough compression, you must remove this membrane. This is the lateral margin of the flavic ligament. This is the membrane on the nerve root. The decompression area. In the lateral X-ray, we must remove the tip of the facet joint, and this is AP X-ray. The lateral margin is located in the lateral margin of the pedicle. and we can expose the tip of the SAP, and the lateral margin of the pedicle is lateral area of the decompression area, and we can use the radio frequency to touch the lateral margin of the pedicle and the medial wall of the pedicle. Why we choose the lateral margin of the pedicle? Because you can see this enough if you do the decompression to the to this area. But we often it's easy for us to find the lateral wall of the pedicle. Another method is you can use the size of the bone to measure the distance of the decompression. And before the operation, you can measure the distance from the MR and the CT. During my operation, I prefer to use the small size the drill to mark the pedicle, the medial wall pedicle, and the lateral wall pedicle. You can see the hole by the small size drill. Then you can make sure the decompression area. This is the tip of the SAP, and the above hole is the medial wall of the pedicle, and the below hole is the lateral wall of the pedicle. We can see the lateral wall of the C6 pedicle and the medial wall is very clear. After the keyhole procedure, we can go on to doing the canal decompression. We can touch the medial wall of the pedicle and the whole nerve root. The case one is a big size osteophyte. We choose the contralateral approach to remove the big osteophyte. The left side is caudal side, the right side is cranial side. We expose the upper margin of the C4. And this is interlaminar area. The inferior margin of the osteophyte. The upper margin of the osteophyte. Why we choose the contralateral approach? Because we can see the gap between the osteophyte and the dura. So it's very safe. Then we remove the free bone fragment and using the small size radio frequency to separate the bone fragment. See, one can see the contralateral side, the facet joint, and the contralateral nerve root. This is a post-operation the CT reconstruction. And this case 2 is a cervical URBD. We also we remove the lateral plate of the laminar. Then we remove the inner plate to expose the proximal insertion of the flav ligament. The same method, I remove the C5 laminar, and we do the contralateral decompression. But no, we in my center, I give up this the cervical URBD procedure. I often choose the single open door or spare tip technique to deal with the CSM case. Spinal process approach is very important. It is described by Dr. Sun. We can see the contralateral side, the laminar. Then we can to do the contralateral side decompression until we find the contralateral side V point and facet joint. I designed the cervical Ube transportal. I think if I choose the contralateral third portal, I can do more works and get enough the contralateral side decompression. This is ipsilateral decompression area, and this is a picture of the patient. And I also to clear the soft tissue between the interspinal process space, and to build the contralateral side of the transportal. You can see the angle of the contralateral side portal is very good. It's easier to do the contralateral side decompression. But if you see more surgical field of the contralateral side, you must remove the basement of the spinal process of the proximal, the cervical vertebra. So further bone work so that we can see the proximal laminar of contralateral side. The angle of the bone is very good. We remove the contralateral side laminar. And we can see the contralateral side of the lateral mass and the lateral under the surface of the laminar. This is contralateral side, the upper margin of the laminar. We can see the insertion of the flap ligament. It is separated by the drill from the upper margin of the laminar. Then I use the small size radio frequency to separate the flap ligament to make thin the C5's contralateral laminar. The angle of the kerosene punch is also very good, because we can see the surface of the spinal cord of the contralateral side, so it's very safe to separate the flap ligament and from the spinal cord. Then we can see the contralateral side of the facet joint and V point. In this case, we also do the keyhole, the ipsilateral keyhole. So we published the transportals article. And the quarterback key portal, I think, is also important for the cervical discectomy case. We found the disc fragment in the axillary area. Then I insert the key wire as a protective retractor through the quarterback key portal. Then I open the annular to do the discectomy. Cervical sliding technique is used for the multi-level cases. I think the two-level case, only the two portal is enough. So, but you must design the exit the position of the two portals. In China, we often do the anterior approach, the ACDF by UBE when we deal with the posterior area and open the ligament to do the decompression of the spinal cord. But this video cannot be played.
Ekran paylaşıyorum. Mavi ekran diyor. Kadehe basıyorum.
I use this arm to fix the endoscopy. Then I use the small size calcium punch to do the decompression. And this is the cage under the endoscopy. And I also do the ACCF by UBE. After I stop the water irrigation, we can see the decompression area. I designed the cervical single open door technique. This is a plate method. I use the detacher to open the door and the left affix the door side by the plate, the spindle side plate. This is the open door side. This is the door spindle side. You can see the plate. I think we choose the spindle side to insert the plate is very safe because there is no nervous structure. So I choose the door spindle side plate. Another method for the cervical single open door is the anchor method. First, we insert the lateral mass anchor. Then I insert the spinal process anchor. We do the note under the oscillator monitoring. We can see the note pusher through the interspinal space. This is the open door side. This is the picture shows the anchor method. We use the lateral mass anchor and the spinal process anchor, and then we make the note to keep the open door. I think this is a very quick procedure for the UB cervical single open door technique. I also do the lateral mass screw by the UBE for the instability case. And for this case, I perform the spare tip technique to do the decompression. Outlook, if we choose the posterior approach, how to remove the disc herniation in the central area or the OPLL in the central area. So I designed the more lateral portals for the decompression in the central area. Another abbreviation is BBE. I think it is different from the UBE. It is an abbreviation of the bilateral biportal endoscopy technique. I hold the endoscopy and tools in one side. My sister holds another endoscopy and tools in another side. So try it and enjoy it. This name is from Dr. Zhu Chengyue of my team. especially for the difficult case and the complex case. For example, the cervical single open door technique. So take-home message include the anatomy, where we to build the workspace, and where is the start point, and we must choose the right size tools and the right operation indications. And the cervical UB and CCM position is also important. The precise the location of the work portal and view portal according to the surgical technique, and then identification of the viewpoint and how to make sure the decompression area. This is a UB China mobile website. There is too much articles about the UB case and UB tools made in China. This is my WeChat. We can keep in touch, contact. Thank you for your attention.
Dr. Zhang Wei for the wonderful presentation. I think Dr. Sicham Muchu is back. So we welcome the next speaker, Dr. Sicham Muchu from Sultan Bey State Hospital, Turkey. Dr. Sicham Muchu is a member of ISUBE and IHTSS, International High-Tech Spine Society. The topic is surgical technique and tips for UBE discectomy. Welcome, Dr. Muchu.
Thank you so much. Hi again, dear colleagues. My name is Çiğdem Mumcu from Turkey. I'm so happy to be a part of this great webinar. I'm going to talk about surgical technique and tips for UBE discectomy. Why do we perform endoscopic surgery, or why should we? It is because smaller incision, less tissue trauma, and less bleeding, less postoperative analgesia, faster recovery, more convenience for obese patients, and recurrence. Even though microdiscectomy is considered a golden standard in lumbar disc herniation surgeries, and endoscopic approaches have become a serious alternative to microdiscectomy, parallel to endoscopic techniques being used widespread in the past 30 to 40 years. In microdiscectomy, we are observing the field from afar, but in endoscopic discectomy, we are working while observing inside the field. It means our skills need to change. Also, anatomic orientation is a must-have. How do we see the surgery field when we look into it endoscopically? It is blood-free and clear, revealing the anatomic structure compared to microdiscectomy. First definition of UBE in literature was made by Dr. Anthony in 1996 as modified translaminar epidural endoscopy. What is UBE? UBE is an endoscopic technique with double portals. One is the working portal, the portal through which we use the instruments. The other is the endoscopic portal in which endoscope is placed. UBE is we know that UBE is an arthroscopic approach to the spine. It is a minimally invasive technique alternative to microsurgery and monoportal endoscopy. When we look into the history of UBE, we see that Dr. Anthony first published an article named Translaminar Lumbar Epidural Endoscopy in Lumbar Discectomies in 1996. Between 2003 to 2013, Dr. Yam and Dr. Son from South Korea developed UBE, widening its application spectrum to all spinal stenosis and fusion surgeries. Basic principles of UBE involve the triangulation, continuous water circulation, and creating a potential space as a working field. In the spine, there is no. We know that in the spine there is no natural cavity as in other joints. So we need to create a working space above the lamina and under multifidus muscle. What are the advantages of UBE? We tell you a smaller incision and less bleeding, and also muscle and ligamentous tissues are not damaged because we dilate the muscles and work in between them. We don't cut any muscles from insertion or separate them. So there is very little tissue trauma and less postoperative pain. Thus, the recovering is faster compared to open surgery and microdiscectomy. With UBE, operating on obese patients and regional surgeries are easier. Also, in UBE, we get a perfect panoramic vision thanks to 30 times magnification. With the help of this, we can see anatomic structures in more detail. Another advantage is that the portals move independently in UBE, which is a great development when compared to the monoportal technique. Another important advantage is UBE's endoscopic trajectory is the same with microsurgery technique, which makes it easier to learn in the training process. What are the disadvantages? The training process is long. It demands experience. Also, cutting-edge technology is needed for the surgeries. The more you practice, the shorter operation time you will need. And following this, the rate of clinical success increases while the rate of recurrence decreases. What do we need to do UBE surgery? We need 0 or it depends on the surgeon also procedure, 30-degree endoscope with trocar, RF device, arthroscopic shaver and burr, arthropump, special UBE instruments, kerosene and pituitary rongers. UBE has a general indication in all degenerative spine cases, and it is indicated in all lumbar disc herniations as well as thoracic disc herniation, peroneal cervical disc herniation, and recurrence disc herniation. UBE is contraindicated in intradural disc herniation, in which subarachnoid field is migrated through penetration of dura. General anesthesia is preferred. Pseudoanaesthesia or local anesthesia can also be used, but general anesthesia is better and safer for the patient and the doctor's comfort. The patient is positioned in the prone semi-flexed posture. There are 2 basic surgical approaches in UBE, and this approach depending on the pathology and the location. For pathologies which are on medial of pedicle midline, paramedian approach is applicable. For the disc herniations which are on lateral of pedicle midline, paravertebral approach is applicable. We use paramedian approach for central, paracentral, and lateral recess pathologies, and we use paravertebral approach for intraforaminal and far lateral disc herniations. Marking entry points is the most important step of the UBE surgery. We have some radiologic landmarks defining the skin points, assessing to the target area using the potential space depends on these points. If you make a mistake during this stage, it might cause a problem. For the paramedian approach, we use 2 important lines. One of them is the interspinous line, which is the midline, and the other one is the interpedicular line. Then these two lines should form a triangle in the center of spinous process on the target level. The distance between the two portals should be approximately 2 to 3 centimeters. The principles of the paravertebral approach are the same with the paramedian approach. Two portals are made in the paravertebral area. These entry points are formed along the imaginary line connecting the transverse process, which is 1 to 1.5 centimeter far from the vertebral body of the foraminal disc level. First, skin incision, a 1 centimeter horizontal cut above the target point is made for the working portal. We dilate the muscles and work in between them. We shouldn't cut any muscles from insertion or separate them. So the potential damage is minimized. We must not form multiple routes through the procedure, and we must be careful in the interlaminar area. After the skin and fascia incision, two dilators are inserted through the entry points and they form a triangle on the lamina. We call this triangulation. This is the most important step in the UBE procedure. And next, the endoscope is inserted through the endoscopic portal, and the RF probe is inserted through the working portal. We try to see the RF on the monitor by forming a triangle above the spinolaminar junction. And then soft tissues on lamina and ligamentum flavum are cleaned using the RF. What are the complications? Sometimes cord or root injury and dural laceration, but this complications is very rare. Incomplete surgery, hematoma and infection rates are lower than in microscopic surgeries. Intra-abdominal fluid collection is very rare, but can be mortal. Increased intracranial pressure may lead to headache, neck pain, or visual loss. To have a successful surgery and avoid complications, we need to follow these important tips. First of all, the working area must be free of blood and clear. For this, there must a continuous water circulation in optimal hydrostatic pressure. It also prevents bleeding in the surgery area. If we move the endoscope deeper, that is closer to the pathology, we can have a clearer vision. In cases such as bleeding, inadequate water circulation, or blurry endoscopic vision in the surgery area, suction tip can be used. It functions as a natural drain. Usually, the epidural vein bleeds, but we can frequently see 3 other arterial branches that can bleed. Coagulation with RF is usually enough for hemostasis. Bone wax can be used in bleedings that are bone-based. For hemostasis, gel foam or hemostatic agent can be used. Systolic blood pressure must be 100 millimeter mercury. And for the resistant bleedings, we should keep in mind that turning off the irrigation and waiting for 2 to 3 minutes will provide a spontaneous clotting. Now I would like to tell my UBE story. First encounter in October 2018. I met Dr. Hayati at the meeting at Medicana Hospital, and first course November 2018. Medical Hospital, and I attended regular attendance for 18 months. First workshop at my hospital with Professor Hayati, January 2018 and 19. Basic course March 2019, and my first case April 2019. I would like to thank you to my professor Dr. Hayati also. You can see my UBE journey. Let's now take a look at the cases. The first one is a 66-year-old male presenting severe pain in both legs, having more severe pain on the left side. Preoperative MRI showed a central rupture disc of L4-5 level. This is I performed UBE discectomy on this patient successfully. After the surgery, the rupture disc had been removed. Postoperative MRI showed the complete removal of the disc particle. Here you can see this intraoperative video. This intraoperative video show us the rupture disc removed. At the end of the UBE, we can see discectomy done well. Here you can see his intraoperative images before the discectomy and after the discectomy. I would like to emphasize that it is important to dominate endoscopic anatomy and endoscopic orientation. You can see herniated disc and herniated disc and nerve root and dura, and so here is the second case. A 49-year-old female patient had severe radicular pain in the left leg. Preoperative MRI showed extruded disc herniation in the L5-S1 level. I performed paramedian approach of UBE. After UBE discectomy, postoperative MRI showed extruded disc was completely removed, and S1 root was well decompressed. This intraoperative video shows us the rupture disc compressing left S1 nerve root. And at the end of the UBE, we can see discectomy done and S1 root well decompressed. These are intraoperative images of the disc and nerve root. The third case is 40-year-old male with a complaint of severe radicular pain in his left leg. MRI showed disc herniation at the left extraforaminal area of L3-4. In the postoperative MRI and CT, we can see that the foraminal disc herniation was removed. The patient's symptom improved after paravertebral UBE. This video shows the paravertebral approach for extraforaminal disc herniation. Here you can see the decompressed terminal disc in these images. As a result, UB in the surgical treatment of lumbar disc herniations can be adopted as a minimal invasive method, an alternative to microsurgery and monoportal endoscopic technique. Moving off both portals independently, wide indications, excellent panoramic view, and detailed information of anatomic structures. Endoscopic trajectory involves the same steps as conventional microsurgery are the advantages of the UBE. Finally, I would like to conclude my speech here by stating that we would be very happy to invite our colleagues to Third World Congress on Spine Endoscopy Congress, which will be held in Mumbai between September 22 and 25. Thank you.
Thank you, Dr. Muchu, for the wonderful presentation. Let's welcome the next speaker, Dr. Hayati Agan. His topic is consecutive decompression in multi-level lumbar spinal stenosis. Welcome.
Thank you, Dr. Khan. I'll start for my presentation. Okay. Waiting for sharing now. Do you see my presentation?
Can you make it the presentation mode? Now I just see in the non-presentation mode, but I can see your slide.
Yes, I'm trying, but I think now okay, right? Is it okay now?
Can you click the next slide and then see what's happening?
No, it's working right?
We are still on your first slide and in a non-presentation mode.
But I turned the presentation mode actually.
Okay, so you need to share screen and not share PowerPoint. So maybe you unshare now and then you click share and then you click share screen. Screen 1 or screen 2, whichever screen. Yeah. Now perfect. Now it's good.
Okay. Is it changing now?
Yeah. Yeah. Very good.
Okay. Thank you very much. I will talk about the consecutive decompression for lumbar spinal canal stenosis. And you see this my presentation plan, and also we will discuss on the literature. And first of all, I want to mention about the nature of the lumbar spinal stenosis, and also briefly, and also I will start with the types of spinal stenosis. Actually, types of spinal stenosis is a matter for the endoscopic surgery. When you choosing your portal placement, portal points, you should consider the type of spinal stenosis. Yes, we have the three main classification: congenital or developmental or acquired or we can see the combine with the congenital unacquired stenosis. Lumbar spinal stenosis has been defined as a condition that involving any type of narrowing of the spinal canal, nerve root canal, or tunnels. Spinal stenosis not only reduces the anteroposterior and lateral diameter, but also alters the cross-sectional configuration of the spinal canal. And also, in endoscopic surgery, especially in endoscopic surgery, we should be aware of the pathophysiology of the stenosis. The pathomechanism and the pathology locations is very important. The pathomechanism of central or lateral spinal stenosis is predominantly related to the degenerative changes, as you know, and the spinal stenosis can be seen in central or lateral portion of the spinal column. Central and lateral recesses or foraminal stenosis can be seen in a single location or in several locations in same level or in multi-levels. So when you try to do the endoscopic surgery for the stenosis, you should be aware of the technique should be available for to access to the your target points. If you look at the radiological cascade of the spinal stenosis, everything is starting from disc pathology. After then, the facet joint arthritis starting, then yellow ligament thickenings and the vertebral body osteophytes can cause the metameric circumferential instability. So we can say that mostly in the stenotic segments, we should be considered, we should be aware of the instability, and eventually we'll see the stenosis. As I said before, stenosis can cause from the soft tissues, for example, disc, ligaments, cysts, tumors, or it can cause from the joints, facet joints widening or hypertrophy. Maybe we can see the bony changes, support, or again hypertrophy parts, and then maybe the deformity also can cause the three-dimensional instability. When the stenosis created by ligamentous, you will see the left side picture, you see, or you can see the bony enlargement or facet joint hypertrophy can cause the stenosis. But in lateral portion, also very important. Actually, I always emphasize that the stenosis surgery actually a kind of lateral recess surgery. If you do not enough lateral recess decompression, you cannot obtain good results. And I said before, the instability can cause the three-dimensional instability. Spinal cord is compressed by posterior structure of the canal, and nerve roots are compressed by the facet joint and disc and ligamentum flavum. The other problem is with the lumbar spinal stenosis. The lumbar spinal stenosis is not a lung disease. Many of other pathologies accompanied by this problem. Even with most patients experiences substantial improvement from surgical intervention. Sometimes pain and disability persist at long term in follow-up. One possible explanation for these continuing symptoms in this patient may be the presence of comorbid musculoskeletal conditions as comorbid conditions limiting walking ability, including knee and hip arthrosis, predict worse surgical outcomes. There are many works, papers about this accompanying these other osteoarthritic conditions with the stenosis in the literature, you can see. But the interesting aspect of the literature, when you look at the results, surgical results, regarding with the lumbar spinal stenosis surgery, you will see the very high success rate. This is very interesting. If you consider the work group, mostly this group, the patient characteristic is available for the osteoarthritic population. For example, we know that after more than half of the patient has suffering from the knee or hip osteoarthritis when they exceed 60 years old. Also, in the multi-level stenosis surgical rates, very high. It's very surprised. But also, some papers say that there is no any difference physiotherapy and the surgery. And also some papers claim that there is no any difference between all the other surgical procedures. Yes, the question is why? Why? If but it should be debatable. Why? Because we know that we cannot be sure about the responsible level or responsible pathology for the low back pain, for the leg pain, for the walking difficulties. We need a more detailed examination. And how can be sure about causes of residual or new symptoms after surgery? Nobody knows. And the other problem is how can be distinct the causes of symptoms coming from a hip, knee, leg, buttocks, low back, or sacroiliac joints. All of symptoms can be confessed. And also the assessment tools also similar, mostly similar. We are using the visual analog score, ODI, and the claudication questionnaire, and the other scores, but they using almost the same assessment tools for the lower extremity pathologies. As you see here, the ODI in the lumbar spinal stenosis, the symptoms mostly we seen intermittent neurological agitation, back pain, leg pain, weakness, numbness, ambulation difficulties, normal peripheral with the normal peripheral pulsations, and the bending or extending related symptoms, and the gait changes. So, if we want to be sure about it, may be impossible to be sure exactly, but if we want to get a good result and we want to be sure about our surgery, maybe we should consider the consecutive decompression. It means that we should follow the nerve route. We should decompress the central portion, decompress the lateral recess, decompress the lower foramina, decompress the upper foramina, decompress the lower foramina of the adjacent upper segment for exiting nerve route, and decompress of the lateral portion of the foramens if needed. And you see some zoom. I always using these tables. You see, in multi-level adjacent segments, consecutive decompression can provide fully decompression of the lateral recess, lower and upper foraminals, and far lateral portion. For example, you see, I just trying to follow the nerve to be sure about. Also, we should be do the preoperatively some workups to define the which level responsible for the symptoms. For example, this case, nobody can be sure about the surgical success for this case because the symptoms can cause many different levels. We have a study about this. We did 118 cases and 72 single level stenosis decompression group 1 and the 46 adjacent upper level decompression as a group 2, and the diagnosis made for single level decompression in multi-level degeneration. And we see the preliminary result at 1 year. We seen that there is very obvious difference about the results. I will show you the case now. This is the multi-level comorbid stenosis. You see, and this is the surgery. Now, for this level, we did decompression. Now, I will show you the first surgery was this. We did fully decompression. In one lateral approach, we did 4 foraminal decompression. You see upper foramen, contralateral side, and lower foramen. And now here, I will show you the ipsilateral foramens. We did fully decompression here. This is the upper lower nerve root here, axilla here. You see, fully decompression. Yes, the ipsilateral traversing nerve root, ipsilateral exiting nerve root here. You see, exiting nerve root. Yes, here is the exiting nerve root, ipsilateral, and the disc. And this is contralateral again. Yes, we did 4 foraminal decompression in one level. Now you can see 4 foraminal decompression. Yes, this is the left L4 and the L5 here. Then again contralateral side L5. Even though this is complete decompression, you can see what happened here. This is the L3-4 level. Now, this is L4 traversing nerve root. We've seen before as L4 exiting nerve root. Now, this is a traversing nerve root. You see here, there is something pushing the disc, pushing the nerve roots here. Yes, this is the part, calcified disc part. So the consecutive decompression is important. If you left it, you cannot get good results. And here is the postoperative results. And postoperatively, we've seen a very good result. And the other case, 78 years old female, left side buttock and leg pain. She was walking difficulty in getting words, and the compensation posture also. And she tried many times physical therapy, but unsuccessful. And we did foraminal injections, and the pain scores are very high. And this is the MRI. We did the injection for this case because of this MRI. You see, actually seems very innocent MRI. There is no severe problem, just in level 3-4. There is some SAP hypertrophy here. Okay, it can explain the pain, but also she has severe L5 nerve irritation, interestingly. So when you assess the case, you should be aware of the dermatomal and the myotomal assessment. If you have any concerns, you should assess with the injection. Now you see the L4-5 level, sorry, L5-S1 level here. Here is the disc. One, two, faster. Yes, there is a disc irritating the nerve root, calcified disc. And also sometimes the laying down position MRIs can not give a real result, for us maybe. We need the compressive MRIs. The Professor Tarık Yazar have worked about this to explain why the case is feeling the pain during the walking and standing position, related pain during the laying down position. Yes, we did the discectomy, especially for the ipsilateral side. Then for L3-4, we did the paravertebral approach to see the L4 nerve roots. See, we did the shortening of the tip of SAP. Maybe you can notice how the foramen is narrowed. Okay, now this is the result. We remove the SAP and we remove the disc from here. And here's the postoperative skin incisions. As a conclusion, Results which related with the stenosis surgery are debated in the literature actually. And the pathophysiology and pathoanatomy of the stenosis should be known. Consecutive decompression may necessarily multilocate stenosis. Consecutive decompression is targeted to decompression of the nerve roots from core to far lateral of foramen. Pathologies of hip and knee are accompanying more than 50% of spinal diseases. Complaints of the hip, pelvis, and knee can be mixed with the symptoms of the spine. Patient evaluation questionnaires for spine disease are researching similar pathologies. Accompanying pathologies will still be continued after spine surgery, after spine interventions or treatments. High success rate after spine interventions should be suspected only if diseases of the spine are not selected. Thank you for your attention.
Thank you, Dr. Hayati, for the wonderful presentation. Let's welcome the next speaker, Dr. Tarek Yazda from University of Ankara, Turkey. He is the Professor of Orthopedics Emeritus, Department of Orthopedics, University of Ankara. His topic is a promising post-operative prediction of decompression of stenosis. Welcome.
And the topic is very nice here, actually. In something wrong, surgery is excellent. Ube technique is much more excellent, but we have some patients post-operatively, they are not happy. Some of them, not all, too much, but some of them. At the conclusion slide, Professor Hayati Aygün showed us some complaints are all together, one by one, all together. So to select, it is very difficult which symptom is the main symptom. And on the other hand, in the preoperative period is very important, maybe much more important than the surgery himself. And there's a gap, exactly there's a gap. Preoperatively, we have to know how many segments causing the pathology. We don't know this. In the MRI, it's a picture. And the MRI, in the horizontal position, the patient is on the horizontal position in the MRI tube. The horizontal people and the standing people, same human, are totally different biomechanics, totally different compressions. We have to select, we have to know if there is more than one segment pathology altogether, we have to know which one is the most responsible from the complaints. And that's why I had a deeply research in the literature, and I saw in the literature there is a very interesting paper. And before than this paper, I would like to talk some of the patients who undergo surgery for spinal stenosis from time to time have residual symptoms and low function and health-related quality of life for some time after surgery. This is a reality. Secondly, when we realize that post-operative cases are not happy after Ube, we wanted to find out a promising and objective predictor for these patients, post-operative prognosis.
Dr. Tarek, sorry for interruption, but we can see only the first slide in your presentation.
Hocam, sunum moduna geçirebilirseniz.
Sunum moduna nasıl geçireceğim şey?
Sunum moduna şu yukarıda bir şey var, sekme. Şey
Evet.
gibi şöyle ekran kadeh gibi kadeh. Üstünde şey var.
Nerede?
Tıklarsak.
Dur aşağıda.
Sol üstte görürsünüz.
Çıkartamadım onu.
Hemen sol üst otomatik kaydet var. Onun yanında kadehe benzeyen bir tane sekme var. Ona tıklayınca
Şu aşağıda olmalı. Bir escape yapayım bir dakika.
aşağıda da olabilir ama ona tıklarsanız daha pratik.
Ekran
Ekranın
paylaş.
sol üstünde, yani sizin sunumunuzun
Heh.
slaytın sol üstünde kadehe benzeyen bir ekran görüntüsü var.
Göremiyorum şey. Allah Allah. Bir bu şeyi bağlayayım şuraya.
Şimdi şöyle,
Şey haline gelsem, bir paylaşımdan çıksam,
olur.
paylaşımdan
Sunum
çıksam.
moduna geçirin, sonra tekrar buraya gelin.
Ha, evet. Allah Allah. Beceremedim ki. O kadeh burada yok ya. Allah'ım yarabbim. Kaydet falan ekran kartı.
Şimdi şöyle, şimdi yukarıdaki kırmızı şerit var bir tane.
Nerede?
Kırmızı şerit var. Bakın bir tane yeni sekme yazıyor. Yeni sekme. Giriş, yeni sekme. Onun hemen üzerinde bir kadeh gibi bir şey var. Gördünüz mü? Yeni sekme yazıyor ya en üstte.
Görünüm var. Ben onlar
Şu dosya olan yere gelin. Dosya.
ha,
En
tamam.
yukarıda. Tıklamayın sadece. Dosya. Oradan sağa doğru geldiğinizde bir kadeh şeklinde bir tane ABC kontrolü var falan. Gördünüz mü onu?
Dur,
Buna tıklayınca
ben-
geçer o.
Bir dakika. Buse benim şeye bağlı da.
Tamam.
İnternete. Bir arayayım onu. Hayati çok teşekkür ediyorum. There is no doubt that the Ube technique is not not to blame. There are many, there may be errors in determining the compression levels. Okay. And in the literature, there are so many papers about this point. For example, duration of the leg pain exceeding 2 years predicted inferior outcome, and preoperative users of analgesic had higher levels of back pain at follow-up period than those not using analgesics. Hayati, bu sağ tarafı nasıl yok edebilirim? Küçük resimler benim şeyimi engelliyor, resmimi.
Şu an hala sunum modunda değilsiniz hocam.
Peki ne yapmamız lazım bu şey?
Şimdi şu yukarıda kırmızı şerit var bir tane.
Tamam, şimdi kırmızı şeriti görüyorum.
Evet, şimdi onu Ken yazıyor ya, Ken'den sola doğru takip edin. Bir
Dur,
tane
şu
kamera
şeyi aşağıya alsak, Buse şu üstteki siyahı nasıl aşağı alacağım?
Şunu küçültmeye çalışıyorum.
Az önce gelmiştiniz üzerine. Az önce gelmiştiniz galiba.
Oraya tıkladım fakat hala
Gözükmüyor mu?
Tekrar çıkıp tekrar girin siz.
sadece tepede olan PowerPoint olarak görünüyor hocam.
Allah Allah. Hayati,
Tekrar çıkıp
Tekrar çıkıp gireyim mi?
Şu aşağıda mesela şey var bir tane. %40 yazıyor ya, bakın aşağıda.
Ben de
I think it's okay if the slide is moving along. We can continue. I think we can see slide 10 now. Maybe you just scroll back and forth and see whether the slide is moving,
Okay.
because we can see the words quite clearly.
Baştan mı başla diyor?
Olabilir. Hocam şu sağda şey var bir tane. Sağ alt köşeye geldiğinizde %40 yazan bir yer var. Gördünüz mü onu?
Allah Allah. Bende yazmıyor şey.
Sizin ekranınızda yazıyor şu anda. Sizin sunumun sağ altına gelin.
Ha, evet, %40 diyor, evet.
Onun
now we
yanında
are
bir tane
slide
kadeh
4.
var. Kadeh
Evet,
yanında. Gördünüz mü
evet,
sonunda?
evet.
Ona
Tamam.
tıklayın. Tamam, bekleyin. O işte sunum moduna geçirmesi lazım.
Geçti mi?
Geçmedi. Sizde geçti mi?
Geçti.
Tamam, o zaman Belki bizde de geçer bir daha. Veya kapatın, çıkın, oraya basıp tekrar ekranı paylaşın.
O zaman dur nasıl kapatayım?
Ekrandan çıkın hocam.
Paylaşım
Ekran paylaşımını kapatın.
kapattım.
Evet. Şimdi oradakini sunum modunda açın, tekrar ekrana paylaşın.
Sunum modunu nasıl açacağız bu şey? Aç şunu.
Aynı şeyi açın. Yine PowerPoint'i açın. Tekrar aynı yere bastığınızda sunum moduna geçin.
Açık. Ekran paylaşımı dediğimizde
Tamam.
Önce sunum modunda açın. Sunumu, ondan sonra ekrana paylaşın.
ekranımızı paylaşalım hocam. Bir saniye.
Şimdi olmuş.
Şu an oldu.
Ha.
Oldu.
Peki o zaman ben
Biraz başa
oklarla
gelin
yapayım.
hocam. Tekrar başlayın. Vaktimiz var.
Var mı? Kaça? Escape mi yapayım şimdi?
Yok. Bir slide önce gidelim isterseniz.
Heh, tamam. Tamam.
Tamam.
Tamam. Yes. And the purpose of this study is in oldu mu Hayati?
Perfect. You can go.
Oldu mu?
Perfect. Yes.
Tamam. In this way, we could determine the number of decompression levels more objectively and more accurately in multi-level spinal stenosis. That's why I had a severe literature investigation, and I saw a very interesting paper, but of course there is no doubt that the Ube technique is not to blame. There may be errors in determining the decompression levels. This is the pathologic point. And the postoperative prognosis, about the postoperative prognosis, of course, there are some acceptable points. For example, duration of leg pain exceeding 2 years, predicted inferior outcome in terms of leg and back pain function and health-related quality of life. Preoperative users of analgesics had higher levels of back pain at the follow-up than those not using analgesics. Low preoperative function predicted low function and dissatisfaction at follow-up. Low preoperative health-related quality of life scores predicted a high degree of leg and back pain. Narrow dural sac area predicted more gains in terms of back pain at follow-up and lower absolute leg pain. So the imaging findings and clinical complaints are not always compatible in some cases. This is very interesting, and this is a reality because in the MRI, we are making a map of the hydrogen atoms, and hydrogen atoms are too much in body. So this incompatibility makes it difficult to determine the correct decompression indication. So preoperatively, we are doing something wrong. And for example, in this patient, complains she had a hip surgery 11 years ago. It's hard to stay in the same position for her. She uses a steel underwire corset, and this corset is helpful. Corset helpful means there's a mechanical problem also. She wakes up 3-4 times while lying down due to severe pain. Pain radiates to left hip, left thumb is worse. And this is the position of her. The index surgery, total hip replacement bilaterally, and somewhere else, and the center of the hip now changed from anterior to the dorsal part. So sacrum like horizontal now, and compensation mechanism are working, and the lumbar lordosis increased. So she is suffering from back pain. Does it coming from the mechanical problem, or does it coming from the neurologic compression? This is difficult to understand. And And what I have seen in the literature, multi-level myelopathy in Morelli syndrome and review of the literature. It's published in Clinical Neurology and Neurosurgery in 2005. And they used a very interesting technique. They used transcranial magnetic stimulation. This is, of course, a kind of electroneuromiography, but it's very difficult. It is to explain, to perform difficult. It takes long time. And from the cranial stimulation, in each segment of the muscles will be investigated with this technique. That's why it takes long time. And routinely, neurologists, they don't like this technique. But it says a lot of things. And the pathology for this patient, according to this transcranial electroneuromiography report, mechanical and neurological. So this patient has neuromechanical instability. And let's go here, here's very quickly. And yes, and these are the results of the transcranial investigation. And these findings indicate the chronic involvement of the L5 and S1 roots on both sides. And we performed for this patient only L4-5 neurologic decompression and the mechanical correction, as you see here. Of course, lumbar lordose is less than pathologic position on the right up, and in the middle with the yellow line, the C7 plumb line, much more physiologic than before. That's why this patient will be happy. So in each stenosis, we have to know a definitely point. We have to catch a definitely success point. And it takes too long time, and I don't want to consume your time too much, but the sacrum also getting physiological position. And the key point here, just now I'm working with a very good neurology professor, and he is able to do this transcranial magnetic stimulation system. And this is another patient. Again, please have a look on the left, 4-5. There is the node up that it's a compression, but just above it, 3-4. Shall I do decompression? 3-4. Shall I do that? And the transcranial stimulation, electroneuromiography, will tell me, yes, do it. Yeah, really, we have done it, and he is very, very, very happy. So the purpose of my speech here, to have a nice message to home. If it is possible, please use this technique preoperatively. Transcranial magnetic stimulation electroneuromiography system will show the localization of the compression, so it will be very good support to the direction of the surgery, which levels. So the postoperative subjective or objective problems will be decreased, and the patient will be happy, because if it is necessary, we will do decompression. This is very big chance, of course. Many thanks for your kind attention. Thank you,
Doctor. Hi. Thank you, Dr. Tarek Yasser, for the wonderful presentation. quite
Thank
an
you.
interesting proposition for transcranial MEP. Let's welcome the next speaker, Dr. Tung Kok from Asdam Fuya Hospital and Memorial Sicily Hospital, Turkey. Dr. Tung Kok is a member of several international scientific associations in neurosurgery, spine surgery, and endoscopic spine surgery. His topic is endoscopic approach for L5-S1 level. Welcome.
Thank you so much to participate to this amazing organization, and really I have learned a lot by previous speaker. So I will share my own experience about UBA surgery, endoscopic surgery. Especially I will focus to L5-S1 level. As you know, this level is biomechanically a little bit different and a little bit difficult regarding to other levels of the lumbar spine. So I start to make surgery. There is now more than 30 years, and I start to make the surgery with the open surgery with maybe some other surgeons here. And I remember the complications of the open laminectomy, especially with aggressive facet joint resection, some instability complications, some pain complications. So later we start to use microscopic decompression by unilateral approach, and maybe probably like many other surgeons here, my knowledge of endoscopic spine surgery has started with the transforaminal surgery, transforaminal decompression. And I had a time that I really believe that I can do all with the transforaminal way. Not only disc herniation, but foraminal stenosis and others. But when I seen the UBA surgery, I was really impressed by the advantage of this surgery. And actually for the stenosis case, I use a contralateral decompression approach for this pathology. And now I will discuss myself which kind of approach I have to select for L5-S1, not only disc pathology, but also stenosis pathology. I have to select transforaminal approach, or I have to select a posterior approach. I use UBA for posterior approach. I don't use a monoportal interlaminar approach. So before every surgery, we make some calculation. We examine the patient. We see the MRIs, the CT scan, UMG, and we are trying to make a target-oriented surgery, because our goal on minimally invasive surgery is to not destruct healthy tissues and to go directly, if possible, to our targeted pathology. Everybody knows some anatomical difficulties for L5-S1 level for transforaminal approach, especially the height of the iliac crest give us many time problems, and many surgeons they tried. I also SAP resection by hand drills or transiliac approach, but me and my patients were not every time happy. Many patients were happy, but there is some anatomical difficulties of this level. And also there is some anatomical difficulties of this level due to dimensions of L5-S1 intervertebral foramen. But there is not only some anatomical difficulties, there is also the surgery duration that we have to take consideration, because when a transforaminal surgery is difficult, it takes time, and we have also a long radiation exposure duration also that we have to consider, not only for the surgical team but also for the patient. So there is some advantage of the posterior approach, and there is some other advantage of the transforaminal approach. With the posterior approach, we have a wide interlaminar space. Many times transforaminal seems to be less invasive, not sure for L5-S1 level. We have less radiation exposure for posterior approach, not only for Ube, but transforaminal approach with monoportal show us clearly the lateral border of the SAP, and surgical duration of the posterior approach seem to be less many times. But let's to see the foramen, the red circle inside is the nerve root, exiting nerve root, and the yellow one is the intervertebral foramen. And as we see, we have both side compressions by pedicle, by SAP or ligament, by interior border of the vertebral body and osteophyte, and by the lower part. So we have to identify which is the real pathology who impact the patient. But we don't have to forget that we have to calculate only by sagittal plan, because all the classifications of the stenosis made by Lee and by Shizas and even other are made by axial cuts. It might like combined triangle. Combined triangle is not a two-dimensional anatomical whole. Now we know that this is a combined pyramid, and foramen and intervertebral foramen and spinal canal also is many dimensions. So we don't have to make our calculation only as we will talk later with a sagittal plan, and we don't have to say, oh, I will go to resect the tip of the SAP with transforaminal and I will finish the surgery. Everybody here now, the classification of Lee about the intervertebral foramen, and many patients, they have their pathology in the entry zone of the foramen, especially in the lateral recess. So, what are our enemies during the surgery? The first one is the SAP, is the superior articular process, but we don't. I don't have to forget that if I make a minimally invasive surgery, my goal is to not give big damage to the patients and to take advantage of these minimally invasive instruments. So the resection of the superior articular process with transforaminal approach is sometimes insufficient because by the transforaminal approach, we see the lateral border of the SAP, but we don't see clearly the medial wall, the medial border of the SAP, who is most responsible by the neural tissue compression and by the complaint of the patients. And when we see a sagittal intervertebral foramen CT scan or MRI, and we see, oh, okay, I will go to cut the tip of the SAP and I will resolve the problem of the patient. We have, believe me, many unhappy patients. So if we want to make a target-oriented surgery, our target is not only a radiological target, but our target is pain generator oriented pathology, surgery. And we have also a ligamentum flavum, who is responsible by compression of the neural structures, as we've seen on many patients. Sometimes we have some subpedicular technique, as we see here, and this is one of the factors of the also of the narrowing of the intervertebral foramen, and we have to take consideration, and if necessary, we have to make a subpedicular resection. We know today that we have some SAP resections completely with good quality, but the patient is unhappy after the surgery, because this is really not only the tip of the SAP or the ligamentum flavum. Sometimes this is the subpedicular technique also, who is one of the compression factor. For transforaminal surgery, the difficulty is the main difficulty is the mobility of the working sleeve is restricted by the size of the foramen, and we have some risks. One of the risks is the incomplete decompression, and by conclusion, the poor effectiveness of the surgery. I use also this hand drills for this surgery, and I tried it for stenosis surgery also. I had some good results, I had some bad results, but with when I use actually transforaminal surgery for L5-S1 level, sure for lateral disc herniations, and also for large central disc herniation. Why I use? For to not distract the neural tissue, to not have a damage of dura or other, and for revision surgery for disc herniation, especially if the patient was operated by interlaminar approach before. It seems to be more easy to remove without to have a war with the scar tissue, and also for exiting zone foraminal stenosis by the classification of Lee. I use transforaminal surgery. So my transforaminal surgery for stenosis is limited only by the exiting zone of the foraminal stenosis, by the lateral border of the SAP. And for transforaminal decompression, we have some complications. One of them is the incomplete decompression. What I mean incomplete decompression, even I mean inappropriate decompression. This is the decompression of the lateral part of the superior articular process. But when we resect only the lateral part of the tip or of the wall of the superior articular process, and when we don't remove in half the medial part of the superior articular process, the compression of the neural tissue continue, and the patient is not happy, and the surgeon also. And subpedicular kinking also is a complication, a kind of complication of the transforaminal surgery, especially when we remove the disc and when the disc tissue lost its height, even foramen lost his height, and L5 nerve root, exiting nerve root, secondary to the surgery, start to have a compression by kinking, and we think that we made an excellent surgery, but some days or some weeks after surgery, we see the patient again with similar painful signs. And also we can aggravate far out syndrome, or we can provocate a dormant far out syndrome when we make a discectomy with this transforaminal decompression. It's a kind of complication that I've seen before. And posterior access, I use UBA. I use it for like every surgeon here, for large sequestered disc herniation, for highly migrated disc herniations, and for stenosis, for entry and mid-zone foraminal stenosis, especially for lateral recess decompression, and also for central stenosis, for the resection, if necessary, of the ligamentum flavum. I'm trying to not resect completely the ligamentum flavum completely, but the lateral borders and lateral extension, especially foraminal extensions of the flavum, I try to remove it. So I know today that contralateral approach has many advantages regarding to the ipsilateral approach, because we have a minimal inferior articular process resection by the contralateral approach, and we can make with security superior articular process medial border and tip resection without big problem. But with the ipsilateral approach, we have to remove more inferior articular process, and we risk to to create some stability problem. Also, excuse me. So we have a minimal instability risk with the contralateral UBA approach. And also we have a better visualization of the superior articular process. As I said before, I start this surgery with the open surgery, and I continue with the microscopic surgery, and I made many contralateral decompression with microscopic surgery, and I had big difficulty for the clear vision, to have a clear vision of the contralateral foramen and contralateral superior articular process. I had to enlarge more and more the resection of the spinous process. Excuse me. I have to make discectomy or not. every time I ask to myself this question, I followed the surgery made by my colleague and my teacher also, Dr. Hayati Aygün, and he didn't make a discectomy. He coagulated the discal protrusion with the radio frequency, like I do also, because when we lost this kind, the conclusion is the loss of the foraminal height. And when we lost the foraminal height, we have a subpedicular kinking after surgery, why we see some unhappy patients some days or some weeks after surgery. So I will give some small take-home message from my own experience, is that I prefer to use contralateral approach by UBA for L5S1 for all levels of stenosis, but especially for L5S1 level. I'm trying to preserve the disc high, so I don't make unnecessary disc resection, especially if I don't have to use a fusion surgery. I am trying to resect, if necessary, generally it's necessary, the medial border of the SAP and the foraminal extension of the ligamentum flavum. Sometimes I make partial subpedicular inferior part of the I remove the inferior part of the pedicule, and I start to my surgery. I follow the bath during the surgery. I many times start the surgery with 0 degree, and I start it sometimes with 30 degree of endoscope. So I think if we have seen in our history, in our surgical history, open laminectomy and his destructive complication, and now we have UVA, especially with contralateral decompression. We don't have to use these modern endoscopes, these modern instruments to be also at the same level destructive like the open laminectomy. We don't have to create any instability of the spine, and we have to remove in half, but not excessively, just to have a healing of the patients. So I use many times this picture to describe the biportal surgery, what can do an endoscope and instrument together that they cannot do alone. I like this picture, and I thank you so much for your time.
Thank you, Dr. Tungkuk, for the wonderful presentation. If any questions, please record it and we will discuss it later. Let's welcome the next speaker, Dr. Ken Ariel from Hospital Virgen del Rocío, Sevilla, Spain. Dr. Ken Ariel is a consultant neurosurgeon in the neurosurgery department, Hospital Virgen del Rocío, Skull Base and Spine Division, Seville, Spain. His topic is UBE and lumbar disc. Welcome.
Thank you for the invitation. I'm sharing my screen. I don't know if you're hearing and listening to me and the presentation is okay.
Yes, I can see that.
Okay, I'm going to put my printer. Well, first of all, I want to say thanks to the organizers. It's amazing to be part of this endoscopic community. We have to publicize this magnificent UBE technique. In Europe, it's not frequently that doctors do UBE. Maybe most in Turkey, but in this part of Europe it's very less frequent, so we have to publicize this magnificent technique. So thank you very much for the invitation. Entering the topic to talk today, lumbar disc herniation have been long considered many years. In this left graphic, designed by Roger Hart, one of, for me, the fathers of the tubular surgery, he showed that the lumbar in this herniation have very few or less complicated benefits when we compare open traditional surgery with minimally invasive surgery. This benefits increased with MIS surgery, with increase the complexity, and finally, in the last part of the curve, open traditional surgery and minimally invasive surgery get together again. Fortunately, endoscopic spine surgery is changing the rule. So if you see in the right graphic, designed by Jin-Sun Kim, for me, one of the father of the full endoscopic surgery, we still see little difference between open traditional surgery and endoscopic surgery. But this difference started to maintain, and even when we increase the complexity, still unmet the gap. So maybe the endoscopic surgery start to change the rules and the opportunity for all these our patients. So the big problem is that you should not start endoscopy in this part of the curve. You must start in this part of the curve, in this herniation. So you have to understand that maybe, sorry, I get again from the trial. So you have to understand that the benefits of the endoscopic surgery for your patient in this herniation maybe it's not too much, but for your learning curve is very important. I think this is a very important paper. It's published by the Korean group in World Neurosurgery in 2018, and they show us the difference between microsurgery, endoscopic, full endoscopic and biportal surgery. And if we see with details the CPK and CRP, the microsurgery have more aggressive to the muscle of the lumbar, and the full endoscopic surgery have better results, and the UBE is in the intermediate part of the inflammation. So when we see especially the VAS, the VIAP for the back pain and the leg pain, the benefits of the microsurgery and the endoscopic surgery is only in the first 1 or 3 days. But you have to understand that the most important thing of this paper is that the 3 techniques have the same benefit, but with the endoscopic, you are less aggressive, that have fewer complications because have less infections, and you are going to introduce in your armament of technique a wonderful endoscopic tools that can give you more important things when you increase the complexity. For example, in this paper, we can see how a high-grade mediate the lumbar disc herniation that is very difficult when you do a uniportal surgery and need more learning curve. When you do it by UBE, you can do it with not many cases. Even when you have a recurrent lumbar disc herniation, when you do by UBE, even when the first case was by a microscopic surgery, you can resolve biportal surgery with less or with a learning curve more short. So let's share what are the initial steps, what are the first tips and tricks. We in all the morning and the afternoon we are I listen all many tricks. So first of all, remember this is a technique that needs 2 incisions. So it's not the problem about the size of the incision. You have to understand that you need some size between each other to understand the triangulation concept that is going to talk in the few minutes. But you need to understand that you not only to open the skin, you have to open very nice the fascia. So the fascia need to open not only in longitudinal, even in transverse way, because this is your soft portal that is going to restrict in part of the surgery. After these 2 incisions, you need to use the dilator. In the endoscopic portal, we usually not use, and in the working portal, usually 2 or 3 times dilator to open our fascia and keep our port open. After that, you can put your endoscope and your irrigation. We think it's not important if you use a pump or if you use a gravity. The concept of the UBE is related that you have to ensure, you have to guarantee that the fluids go out. If your fluid go out of the body, always your surgical field of view keep clean. So sometimes you need some retractor, not especially retractor. There are never retractors that we use in open surgery to keep the working portal open. One of the difference that I find when I move from uniportal to biportal surgery is in the obese patient. In the obese patient, as you see in the right side, you have more subcutaneous fat. So you have to understand that this subcutaneous fat sometimes collapse your soft portal. So in this obese patient, you have to keep a connection between your skin and your fascia, and it's more important to maintain this semi-tubular retractor to facilitate the output of the fluid. My mentor, Dr. San, used with an assistant this semi-tubular retractor. This is me with my assistant that is retracting. Now, I usually, in grand part of the surgery, use this L retractor that you can put in your lumbar spine without need that your assistant is retracting all the time. And when you need to retraction more than a narrow structure, you can use something with more handle. Another tips that I want to share with you is you have to remember that the carries from rongers, that is very, very important tool. You always need to get into the lumbar spine close. If you put the carrison open, the sharp parts can make sometimes a multi-track in the fascia. So if you damage the fascia in the multi-track in the working portal, not only you are going to fight when you have to get into the working portal, your fluid output is going to not understand where it have to go out, and your field of view started to more difficult to see. So the concept of triangulation is that when you are in the ground, you are seeing your instrument. This is a concept that spend 8, 9, maybe 10 case to understand correctly. If you do the incision so far, you are losing your instruments. It's very difficult to understand where is your instrument. My first mistake is to do the incision so close, maybe because we are afraid and we thinking more in convert the surgery if we have problem. But to do the incision very close is very, very difficult too, because when you are in the ground, our instruments started to fight each other because we don't have space. So you have to get up your endoscope and put your carries around you. So you have to think this three-dimensional triangulation in your surgery. This keeps time, but in 8 or 10 cases, you understand this triangulation. Again, about the fluid, the tips, is not important the pressure. Is most important is the outflow of the fluid. If you see my back is at my head, I'm 1 meter or not more high than that. But look at this, look at my hand. This is most important. I try to open my working portal because all the fluids is go out and I can see very, very well. Look at this video. This is the pressure that I have only with the back at the height of my head. You can do, when you think in lumbar disc herniation, many incisions. You can do an ipsilateral or paraspinal approach, contralateral approach if you are thinking to do a foraminal approach, or a paraspinal approach if you have an extraforaminal herniation. We usually draw 3 lines to understand where is our incision. The first is the middle line, the second is the middle pedicular line, and the third line usually we put in the upper part of the disc, but you have to remember that sometimes the patient in L5S1 is too tilt, and sometimes you have to move these incisions. We call these tips the 5-minute rule. You have to remember that you only have to spend no more than 5 minutes to find your spinolaminal angle. If you spend more than 5 minutes to understand where is your spinolaminal angle, you are losing your time. Something is wrong. Stop your surgery, put your C-arm again, and try to understand what happened with your triangulation. So you only need 5 minutes to understand where is spinolaminal angle, and after that you can remove this soft tissue that is in the zone space on in the multifield fasciculus. So no more than 5 minutes. Remember that your setup is completely different than the open surgery. You need an AP view. This is my usually setup. In the complex case, for example, in some patients that I'm doing a UBE, for example, in deformities, I keep my C-arm in the AP view all the time to understand if I disorientate in some moment. Look at it, it's very ergonomic to maintain this C-arm when I'm working. Look at this. We need 3, 4, 5 instruments, the same as the open surgery. We now need more technology that we usually use. This is an example, a case of L5S1. We recommend you to start this with this kind of case. L5S1, not very nice migrated with a very interlaminar space. We do an IP view, trying to identify where is the space, and started to find. 5-minute rule, remember spinolamial angle. We are in the left side, medial in the upper part of the screen, lateral in the inferior part. So after we identify the spinolamial angle, we can remove the flagrum ligament. We are the flagrum ligament you can remove in many ways. Always we think that in one piece is more easy, maybe it's more fast. So you have to detach first in the upper part, in the upper insertions, then try to detach from the medial part of the SIP. And finally, this is the upper edge of the S1 lamina. This part of the keratome is more difficult. Sometimes you have to move your keratome contrary. And after that, you detach all the part. You can remove the flagrum ligament in one piece. Trying to understand if you have some epidural bleeding where it is, and removing without risk of dural damage. In this case, for example, I tried to find exiting the transversion root, but the fragment disc is so high, big. So when I try to dissect, I don't understand where is the S1 root. So I decide to decompress first. I think it was I work in the axilla of the root. Try to detach. Look at my system now is retracting part of the neural structure. And after I decompressed the canal with a huge part of the lumbar disc, I can dissect the S1 root and understand that I was working in the axillary part. And then finally, look at this. This is S1 root. It was very difficult in the first part to understand. And then I'm working in the shoulders of the root, and I finally complete the secretectomy or the disectomy in this case. It's very, very important to shrink with the radiofrequency proof to reduce the recurrent disc in these patients. We completed with some laminectomy to detach and to see all the S1 root completely decompressed. This is my usually incision. It's not the problem of the site of the incision. Is the problem is you understand that you need to understand that not to damage the soft tissue. Look at the post-op MRI. The soft tissue of the muscle are amazing. The working portal is always bigger than the endoscopic portal. A more complex case, for example, this is a 38 years old female with 2 lumbar disc herniation, L3, L4 from the left side with the lateral vessel stenosis, and L5, S1 from the right side. The patient have a very important neurologic claudication and have pain in both sides. We planified always in the left side of the patient a surgery from both sides in 2 times. So we started first with L3, L4, trying to remove, look at this, 5 minutes, spinolaminal angle. We are now drilling the inferior part of the L3 lamina. Then we try to remove all the flavul ligament. In this case, we remove piece by mill. This L3 or 4 hernia have down-migrated and dissect the body of the L3 vertebra. So look at this; it's very, very attached. So you have to detach with the RF proof and try to dissect, to try to move all the caudecina to the medial part to find where is the lumbar herniation. For very difficult case. Now we understand the anatomy and we can remove all the fragment discs without any problem. After we finish this in the same setup without moving nothing in the OR, we started the L5 S1. So now the lateral part are in the superior part of the screen, the medial part are in the inferior part of the screen. So now we are in the right side, but we are the surgeon is in the left side. Drill the inferior part of the L5 lamina, trying to remove and block all the flavul ligament, and when we retract S1 root, we can now see the lumbar disc herniation and the fragment that is in the canal. So UBE give us a lot of results and tools to remove samples, a more complex case or lumbar disc herniation. So our conclusion are UBE is not the best technique for the discectomy. Few difference with the open surgery, but the discectomy is the best technique to start UBE. So you need to start with this easy case to improve your technique. For the patient, maybe the UBE is the same, but for your hands, always is the best way to start this amazing technique. So thank you very much to the invitation, and if you want, I can answer the questions.
Thank you, Dr. Ariel Khan. I'm really amazed by your by all your wonderful drawing and all the difficult concepts. You managed to draw them out in very nice videos. I think you must have spent a lot of time on it.
Thank you, because I know that all of you are very tired because it's a very long day. So thank you. Okay,
so we have some discussion before we pass the hosting to Dr. Hayati. Is there any question on chat box or anyone who would like to ask any questions for the past five speakers? Yeah, I think the benefit zone is, I really agree. We spent a lot of time in the last few sessions on the basic technique, but I think that really these basic techniques build up actually the complex, subsequently complex cases that leads to the maximum benefit zones. So what are the challenges that since we are here for looking at Europe, what are the challenges in the Middle East, Europe segment in bringing biportals to those countries? Do you find any challenges?
Well, I can talk about Spain. In Spain, the challenger is they introduce a new technique. It's not easy. Sometimes we need to do in the private medicine. The Uniportal, for example, sometimes very costly, very expensive, and that was, for example, in our case, the explication that we moved to the biportal surgery. We started to do uniportal, and it's so expensive that you need to find an amazing surgery like full endoscopy, but with less cost. So UBE not only talk about the cost, but in Spain, biportal surgery give us our patient the amazing result of the endoscopic surgery, and we can do it with less investment, because full endoscopic is so expensive here in Europe. I don't know in your country.
Yeah, I think that's similar in Asia as well. Personally, I do both biportal and uniportal. I'm in a university, so I do randomize decompression, almost similar numbers in both arms, and I find that there's really not much difference in my hands, the clinical results. So biportal by usually have a lower cost to this because of the just because of the equipment. However, biportal do need more equipment in the sense, because we need typically 2 radio frequency compared to uniportal, sometimes one or two radio frequency. It's an interesting topic, and social. It's all by geopolitical. When I was trained in Korea, they bought all the uniportal sets. They have 5-6 sets there, so cost will be brought down. Yeah, so I think with more volume and then more people using, naturally, just like knee arthroscopy, shoulder arthroscopy, and other things, the cost will come down. Yeah.
Yes, I think. Sorry, I think that we need to do that other team, or are you do uniportal or you do biportal? I think spine surgery, MIS spine surgery, need to understand and to have the skill to do the both, and to have to choose. For example, in lumbar disc herniation, maybe uniportal is better, but if you have to drill or to do a laminectomy or to improve your bone working, UBE have more tools, in my experience. So I think sometimes I find some surgeon that is, oh, I am uniportal or are you biportal? I think that we have to learn both, and you have to choose what the patient is need and try to understand both procedures.
Having said that, it's a challenge. Like Dr. Yi said this morning, that this afternoon, that we have the limited number of cases, so by choosing different techniques, then your learning curve just got a little bit even more steeper. But I think it's the most ideal situation is to learn both techniques.
Dear Panhan, I have a question for dear Ken.
Okay, please.
Dear Ken, when you need to C-arm verification of your accuracy of your position? When do you need the fluoroscopy control?
In my 5 minutes first.
Yeah.
maybe sometimes in the end when I try to do a contralateral decompression and the patient have a very degenerative anatomy and I don't feel if I'm in the foramen or extraforaminal, so maybe I put my ball tip and I try to relax and put the C-arm again and try to confirm that I'm in the contralateral and I confirm my decompression.
Thank you. So I have a question for Dr. Chang Wei. Is it possible or later?
Dr. Chang Wei, are you around?
Yeah, yes.
No. Okay. I impressed your wonderful presentation about the laminoplasty. And I wonder if there any biomechanical study of your plate or tensioning band system. How can be sure about the stability of the lamina after surgery? You know, there are many of very strong muscles attaching to the spinous process and also lamina, and you're doing just contralateral side plate tensioning band system to stabilize the lamina. How can be sure the stabilization? Do you have any biomechanical study or just your experience?
You mean the plate method? During my the single open door procedure, first the thing is important. I will cut the spinal process. First, I will from the basement of the spinal process is similar to the open surgery. First, also is similar to the spare tip technique. Then the tip of the spinal process will go go upside, and for the multiple levels, the open door procedure, there is too much the muscle, and it is difficult for me to keep shed off the muscle to the lateral side. I think it is difficult because when I to insert the plate, if the local water pressure is not enough, the workspace will very narrow, and the muscle will go inside the endoscopy. But for one level case, is very easy, and because the screw is very small, and when we insert the muscle, the screw will go outside of the holder. So no, I basically I have give up on the plate method. I use the anchor method to keep the open door to keep the open door, and I will let the sport medicine surgeon to make the note in my contralateral side, and maybe the SMC note and other the shoulder arthroscopy note So the note I think is enough strong to keep the open door. Another detail of this texture is how to make the spindle, the door spindle. Because under the endoscopy, we can see the inner plate of the laminar. So after I make the door spindle, then I change to other side to make to open the door, and I use the detacher to detach the laminar. Is some majority of the time is very easier to open the door, because the spinal process is cut. Yes.
Okay, thank you.
So
Professor
it will
Wu.
be really interesting to see Dr. Zhang Wei maybe in 1 to 2 years time to show your results. Do follow up with them on CT scan and see whether any problem with the closure of the laminoplasty or patients with pain in the neck. I think these are some questions that we will like to find out. I think, but it is a wonderful technique, and it may be a game changer in the future of UBE. Once all these questions that we have, like all the innovative techniques that we always have, such questions, and do keep us update us on the results. Thank you for your wonderful presentation.
Yes, in my opinion, I think when after the operation, we often check the MR. We can see the first good result of the technique. I think is maybe the single open door technique or spire tip technique, but the result of the cervical URBD, in my opinion, is not very good. So in my center, I will choose the single open door technique or spare tip technique for the SCSM patients. I give up the cervical URBD technique.
I think Professor Shi raised his hand, so would you like to come on and make some comments?
Yes. Thank you. Thank you, Professor Wu. I have a question for Hayati Evin from Turkey. Your live surgery is wonderful and skillful. We learn a lot. I have a question for you. For foraminal stenosis, I think it is an advanced technique for UBE decompression. So for foraminal stenosis, there are two approaches. First, contralateral approach. Second, far lateral transforaminal approach. Two approach. How to choose the two approaches at L4-5 level or at L5-S1 level? How to choose the two approaches?
Thank you very much for your wonderful question. Yes, it's a challenge, you know, especially in the lower segment nerve roots, the eratomes and myotomes can be not too easy. It's not too easy to distinct the spine areas. So mostly the both of level has similar symptoms in the leg. So if the first tool is the injection, actually the first and the single tool is injection. Before the surgery, I doing one level injection. After that, following the case, if the symptoms is relieved, okay, I say that this level should be responsible for this. If any suspicion about this, I'm adding the other level injection after 3 hours, 3 or 4 hours, and I'm comparing the symptoms relief levels.
My question is, for single level foraminal stenosis, that's a single level. One level.
Single level, okay, single level.
Foraminal stenosis. Foraminal stenosis.
Yes.
Contralateral route or transforaminal lateral route. How do you choose?
Yes, very nice. Okay, because of this, I always recommend that you should make a very strict and detailed radiological workups. You should do a very thin slice MRI study, or you should see all the facet joints, about 1 millimeter slices. When maybe you can be sure about which location causing the compression. Otherwise, you can miss it. It's easily, very easily. If I have any suspicion about this, I always adding additional decompression. For example, I did central or lateral decompression, but I have some suspicion about this. Now I adding the paravertebral or upper level decompression.
Second question. If the foraminal stenosis caused by SAP tip,
yes.
If you choose contralateral route, how much SAP tip be rejected?
Yes, very good. Another question. Yes, actually, you know, I always following this disease now, the superior facet syndrome. If the tip of SAP exceeding the disc level toward the caudal side, you should cut at least the same level with the disc level. Because when the case make a lumbar extension, if the tip of SAP exceed the disc level, it is possible to make the narrowing. But if you cut the disc level, the tip of SAP, you can be sure about the decompression.
Thank you. Thank you.
Okay.
Dr. Hayati also very interested in your protocol when you do multi-level nerve root block, not nerve root block without steroid, I suppose, and then subsequently at the end of the day do decompression. So let's say a patient with L3-4 and L4-5 foraminal stenosis. You are not sure which level is involved. Can you run through with us how you admit the patient? I mean, it's really interesting that you can get it done in the same day. Maybe you can share with us how you do that.
Of course. You mean the information about the patient?
So what you mentioned is you block L4-5 first, and then you ask the patient, are you feeling better? Right? Is it something like that? Then you block L3-4.
No, we are following the pain questionnaires.
Okay.
Yes.
So if you block L3-4-5 and 3 hours later you ask them, are you feeling better?
asking them what about your pain?
Yeah.
If saying okay, but you know it depends on the patient station. For example, for the very complicated cases, maybe you need one more day to assess it.
Okay.
Yes.
So So when their pain is relieved, you decompress them, right? You don't wait for them to come back a week later. Then you know what I mean. When we give pain block and nerve root block, we wait for them the pain to recur, then we operate on them. I find that is in the end makes patients unhappy because then they have to come to hospital twice. So I really feel that your protocol is quite good. You can actually so once they feel better, you decompress the level, correct? You communicate with the patient beforehand.
Yeah. Yes, always the communication with the patient is very, very important. You should give in detail information about this procedure, but I always give information about the procedure. For example, I think that if I'm not sure about your level, I will add an additional surgery for you, for the patient. It's very important.
Sure.
胡教授，
yes.
那个中国的医生比较多，你把刚才那2个问题关键点翻译2句，用中文。
Okay.
谢谢。
Dr. Hayati, Professor Shi asked me to translate it in Chinese, so pardon me for our European colleagues because there are quite a lot of Chinese listeners. So I just translate for a while. I'll be speaking in Chinese. So, 徐教授问Dr. Hayati 那个出口根那边狭窄，要怎么去决定要从far lateral transforaminal 从外进入，还是从内 contralateral 从内出去的那个想法。然后 Dr. Hayati 是说我们需要用很详细 1 millimeter 的那些MRI 的从 coronal 跟 axial cut 来看那个哪一个地方狭窄，才能判断是从外入还是从内出。另外一个观点，徐教授问那个 superior articular process 就是在哪一个地方要切多少才可以比较适合减压？那Dr. Hayati 说他们要把那个 SAP tip 要切到差不多从在 disc 的下面，那才足够，因为在一个人站直的时候，他那个 SAP tip 如果比那个 disc 还高的话，就会造成 foraminal stenosis 狭窄的那个状况，所以这2个问题解答就是这样。
In addition, you know that the nerve root course is crossing the disc in the posterolateral portion, about the mid portion of the disc. If you cut the tip of SAP from the mid portion of inferior end plate, maybe you can be sure about the decompression.
OK， 差不多在 end plate 下端的那边切割那个 SAP tip 就会比较确认那个减压的效果。
I think the upper wall of the pedicle is also an important landmark for the removing the tip of SAP, because the disc level is too close to the upper wall of the pedicle. 这个徐主任上次咱们讨论的还是，我觉得这个中根的上臂也可以作为一个参考。
Hayati,
Professor Zhang suggests to go lower, right? To be at the pedicle level. Yeah, so that's basically is below the base of pedicle. Is that what Professor Zhang is suggesting?
抱歉，我用中文说一句哈。Hayati 提的是呢，上耳部肩部要切到椎间盘的下中板水平，他是这样提的。我觉得不管上中板、下中板，至少是个指标。如果你要切到中根的上缘，就相当于把上尾突全部切下去了，这肯定是影响稳定性的。 所以我一直在关注这个问题。
但是上关节突的主要承载面积还是在中根的上方，它的还是在中根的上方是一个很大的托盘的。
Thank you， 艾云 ，Thank you。
Thank you very much.
Thank you, Dr. Wu. I think it's a long time for you. It's very hard. Thank you very
Yeah.
much.
So I pass the
Also-
baton. Yeah. Sorry.
Also, thank you, Dr. Hayati. He performed the excellent the surgical demonstration and also gave us the lecture. It's very hard.
Thank you very much. Thank you very much, Dr.
Yeah.
Fangwei.
And we have to work Dr. Hayati harder now, since he's the host of the next part. Dr. Hayati really worked you hard today. Thank you so much.